COVID-19, a community's response. My name is Gabriella Gordon, and I will be your moderator this evening. Please pose questions to our panelists using the Q&A tab at the bottom of the Zoom screen. To begin, I would like to introduce our distinguished panelists. We have with us today Dr. Alla Stanford. Dr. Alla Stanford is the first Black female pediatric surgeon to be completely trained in the United States, as well as the founder of the Black Doctors COVID-19 Consortium. Next is Dr. Armand Henderson, who is an assistant professor of medicine at the University of Miami, as well as an advocate for the homeless communities of South Florida. We also have Mr. Ben Linville Engler, who's a member of the Massachusetts Manufacturing Emergency Response Team and the director at the Massachusetts Institute of Technology's System Design and Management Program. Nearby, we have Dr. Charles Hardin, an assistant professor of medicine with Harvard Medical School and a physician over at Massachusetts General Hospital. And coming to us from New York, we have Ms. Mariama Dia, an MPH candidate at Columbia University and a case investigator with New York City Health Plus Hospitals, particularly in the neighborhood of Harlem, New York. Thank you all for the work you've been doing during the pandemic. Can you each begin by giving a synopsis of some of the work you've been involved in during the pandemic and when you first got started?
Good evening, and thank you for that introduction, Gabriella. My name is Alla Stanford. I'm a pediatric surgeon and founded the Black Doctors COVID-19 Consortium. In my mind, it began on April 3rd. The first time I saw a report that African Americans were dying at a rate greater than everyone else. And I reached out to city, state, and local officials to say, how can I help? And there was not a concerted effort in the African American community in Philadelphia. And as a private practice doctor, a businesswoman, and access to testing kits, and friends who are board certified licensed clinicians and nurses and medical students, I reached out and said, the city needs you and they need us. And we started initially going door to door. That turned into church parking lot to church parking lot, which turned into labor unions, turned into street corners and parks all over Philadelphia. We're now up to 8,000 people whom we have tested. And I'm proud of that and grateful to the citizens of Philadelphia for trusting us with their lives and livelihood.
Thank you, Gabriella, for the introduction. And yeah, I guess in my mind, we pretty much started at the beginning of March. We have a crisis response team here in Miami that's made up of community organizations, and we normally respond to these type of crises during hurricane season in the vulnerable communities that we serve. Opa-locka, Miami Gardens, Liberty City, and Overtown. And once we saw that the pandemic was getting worse, that it spread to the United States, and then the government response early on, we actually started calling individuals that we normally organize with and the organizations, and we actually started to do the same thing that we do during hurricane season, which is reach out to vulnerable populations over the phone, telling where testing sites were. We would pay for people's testing to get done, and just educating individuals. And then when they mandated that people had to stay in the house, we sort of switched our focus to homeless individuals in Miami-Dade County, which the majority of them happen to be middle-aged Black men. And so one of the things that we noticed is that individuals were defecating and urinating on the street, and they didn't have access to showers or hand washing stations. So we set up a general hygiene site at a local church. and we began to service these individuals at the church. But outside of that, we've been doing crisis management. We've also been calling out government organizations for inaction of this population. And also, I've been working at the hospital too. So it's been pretty crazy.
Hi, Gabriella. Thank you for having me as well. And it's great to be on a panel with everyone here who's been part of the response in different ways. My effort started, I want to say, in mid-March. As part of MIT, I saw a lot of projects kind of starting up around campus and within the community, looking at different ways of either developing PPE or other types of devices to try to help support those on the front line working. And through those efforts, on March 20th, I was asked to join the Massachusetts Manufacturing Emergency Response Team that was convened under the Massachusetts Technology Collaborative, which is an economic development agency of the state. And our mission was to determine and support local and regional manufacturers that don't typically make medical devices, but might have the capacity and capability to pivot their operations to produce PPE at scale. And through those efforts, we were very much focused on the surge here in Massachusetts, which was originally, I think, modeled to hit sometime between April 10th and April 20th. And we've continued that work to help over 50 different companies pivot their operations to produce face shields, face masks, surgical masks, respirators, a lot of isolation gowns of different types, hand sanitizer and other supplies like test swabs. That work has continued to evolve now, where I'm helping lead a sub-team of the MERT that is connected with folks from the Harvard Global Health Institute and the Southward Center for Ethics to help develop an end-to-end framework that really looks at testing, contact tracing, and supported isolation in conjunction, and understanding supplies that are needed, workforce development, and really how funding plays a role in this, and ensuring that it's not just folks that can pay for testing that have access to testing. And so that work has continued on, and we're currently in supporting the discussions in Washington right now around the current legislation and looking at funding for testing.
Thanks everybody for inviting me. For me and us at Mass General, the whole thing started a little earlier. Mass General for a number of years has been designated as the regional center for something called NETEC, which is a national consortium for unusual and high-risk pathogens. And so we were watching the COVID-19 outbreak starting in January, and the hospital stood up our emergency response system about the second week of January, because we expected that it would come. And we had an infrastructure in place to do that. So throughout January and February, that was mostly planning. And then as we got into to late March and April, that was mostly clinical care. And then the other thing that we got involved in is it became apparent to us early in the planning process that the number of patients was going to be large enough that we weren't going to be able to take care of them, at least the more severely ill of them, in our normal ICU. And so we had to expand that capacity, and that meant expanding personnel. So we spent some time thinking about educational structures and how we could educate new providers who might be unfamiliar with taking care of ICU patients. And we started something that was initially just a nightly email to our own providers in our division, and then eventually became what we called the Fast Literature Assessment Response Team, or FLAIR, which was a nightly email summarizing clinical topics and new research on COVID-19 that went out by the end to about 6,000 people worldwide. And that initially was just an educational effort, and then it kind of evolved into an effort to combat a lot of the bad information that was out there in the outbreak. I think one of the really interesting dynamics of the COVID-19 outbreak is how low quality not only much of the national leadership is, but much of the communication around the virus and clinical issues. And so we saw FLAIR as a way of combating that. So we were doing that and working pretty much full on through about the end of May, and then the peak passed in Massachusetts, as others have said, somewhere around the third week of April, and now things have settled down again.
Hi, everyone. So I first got started with COVID-related efforts around March. So I'm an APH candidate at Columbia. And so when I first got involved, I was basically working with employees at different hospitals who were trying to get clearance to go back into work. So Columbia has this thing called the COVID-19 Student Service Corps. So I was working in workforce health and safety. And so I was talking to employees on the phone, trying to get a hold of what their symptoms are. And I really like talking to people and seeing how they were feeling. And so when the news came out about contact tracing, I thought it'd be a really great opportunity for me to continue what I was doing. So I'm originally from Harlem. And so what they're really emphasizing is getting contact tracers who are from the communities who are affected very heavily. So it was a great way for me to talk to people who are from my communities and to get them information that they need in a very timely manner. So basically what I do is I call people who are contacts and who have confirmed COVID cases, and I get them information as to what kind of resources they need in terms of self-isolating safely. So whether they need a hotel room, whether they need letters to get off from work in order to still get paid, whatever it may be, we need to connect them to those resources, because if we don't, obviously the spread will continue even further. So I've really enjoyed doing that. It's been a really wide array of different responses from our calls, just because it's very confidential information that people are sharing with you. And it takes a lot of self-empathizing and just also understanding how, just how sensitive of a topic this is. Like, this isn't just numbers on a paper. This is like actually people's real lives. And if you don't have that kind of mindset when you're talking to people, those calls are not going to go very well.
Thank you, thank you. And as you mentioned, you enjoy talking and seeing how people are feeling. And I believe that perfectly leads into our next question. Seeing as how the pandemic has implications on our own mental health, can each of you share how you've emphasized self-care in your own lives recently?
So for me, the biggest thing I do is turn off my phone. Like, even right now, I'm in the midst of this, and this phone has been incessant, worse than when I was a pediatric surgery fellow. And so I turn it off. I leave it in the car. I don't bring it in the house with me. That's probably the single most. And then certain days, we just don't test at all. The testing is very challenging. It's hazardous, for one. It's hot right now. First it was cold, and you couldn't feel your fingertips when you were outside testing. And now it's like 100 degrees. So just dealing with hydration of the people working with, and then also the people you're taking care of, who sometimes are having acute, events at testing sites. So the biggest thing, honestly, is the phone, and taking time for myself. And if the phone is off, then I can't be reached except by my husband and my children. And as long as I know they're okay, then everyone else can wait.
Can you hear me? Sorry. I have to be honest. I wear many hats in the community, in the hospital. I'm still full-time employed at University of Miami Hospital. I'm also an organizer with Dream Defenders. And with so many crises going on at the same time, it's just been really hard for me to actually figure out when the best time is to worry about like my mental health. And with that said, I do try to emphasize that people should take time off and should, as Dr. Stanford said, turn off the phone, etc. But for me, I never take heed to that advice, and I really should. But I think the time that I feel like I'm best in terms of mental health is when I'm spending time with my family, when I'm with my kids, my wife, and when they're around me, I can smile, I laugh, and just I can forget about what's going on temporarily around me. So I guess that's how I try to emphasize that.
Yeah, I would say I kind of fall into a mix of both of those. I think I'm guilty of filling the cup of time often, and My wife and I, we have at the time started out just shy of 1 year old. He's now 15 months old. And so we've been balancing work from home with him. And I think a lot of it has to do with how we spend time with our son and seeing him grow in this. The other thing that we've tried to do more recently is at least plan something big each month that we can sort of look forward to. It gives us, as this started, we thought maybe it'd be 2 to 4 weeks, and now we're into, month 4. And so looking at some of those stepping stones that we can look forward to plan out. I think for me as well is a lot of the work I've been doing on this front has been on a volunteer basis. I was fortunate enough to have support from my program at MIT and a lot of the work early on. But trying to balance all of these things is really just needing to try to prioritize what's most important. And I think, as others have said, ensuring our families are healthy, well, and safe is sort of priority 1. And then how we work from there. I think looking after ourselves while understanding that this work is quite important.
Yeah, I don't know that I have any special insight into that other than what other people have said. I will say, and I think one fortunate aspect of the sort of complete mobilization that we've had at the hospital is that I've taken a lot of inspiration from our colleagues and as well as our institution worked. So, there was some satisfaction even in the peak of it back in April of going to work every day and doing something that mattered with people that you admired and an institution you believed in. Obviously not everybody has that, but that was a great source of comfort to me throughout the whole episode.
I think for me, praying is really important in order to keep my mental health at a good place. So just keeping up with that throughout the pandemic has been really just helpful in nurturing me. And then obviously taking some time away from my phone, which is very hard for me because obviously your social life and your work life is now just always through technology. So just finding times, even if you're taking a walk, maybe just take your headphones out and just try and listen to nature. It's hard to do sometimes, but from time to time, it's really helpful in order to just, stay connected with the world around you instead of always just being glued to your screen.
Thank you. Definitely, many of you guys have emphasized the balance that is necessary as you continue the work you do while also taking into consideration your mental health. And I can speak for the attendees and everyone else saying we truly do appreciate your work. And I think from then I would like to go on to how you guys combat misconceptions about the virus, and what communications do you think can be used by the media, by governments to communicate more effectively? In essence, what do you believe is missing from the narrative currently?
I think you have to listen. You have to see where people are before you speak. And in March, we were just doing public service announcements. People kept calling. I was on the phone all the time. So I just started uploading videos about the myths. I did a lot of Facebook Lives and Instagram Lives with different generations because what church folks are concerned about and what the 18 and 20-year-old folks were concerned about were different. So we dispelled a lot of myths that way and met people where they are. I didn't argue if they said 5G was the reason why coronavirus was here. I said, okay, 5G it is, but you still need to wear a mask and you still need good hand hygiene and you still need to socially distance and you might want to get tested. And so that was my approach. In terms of what would be helpful, at this point, there's been so many mixed messages and so much distrust depending on your ethnic background, and particularly in the African-American community, that having community leaders and elected officials that reflect the population that you're going to is a must. It's just, everyone is tired of hearing the message change every 48 hours. And so, and we'll get to this later, but one of the things I am most proud of is being that voice, the gatekeeper, the protector, if you will, and a source of unfiltered information. And if you don't know, it's okay to say you don't know, but I think too often that's not what we heard. So.
Yeah, I want to echo what Dr. Stanford says, specifically in the African American community around Black people. There is this distrust of the government, specifically around things like vaccines and experimentation that has happened in the past that we've never rectified. And I think because of that, when any excuse comes up to why we're in the position that we are, you know, Black people in particular are ready to say, yeah, I believe that, you know, rather than, you know, what's really going on. But on the other side, it's also capitalism. You know, I think the elephant in the room is that there's been a big push to open up economies. And so they want to push out this information. And so really breaking it down and telling people like, look, they want to get you back to work. You know, they want to get the economy rolling because we live in a capitalistic society and this is what you're supposed to do. If you're at home, then they have to, you know, pay things like unemployment and other benefits that you actually deserve. And I think that's one of the reasons why we are in a position that we are today, because there is a concerted effort around miscommunication, and it's targeted towards different populations different ways as well. So yeah, being that voice, being able to distill it, to break it down to individuals on both sides of the aisle, whether they're Black or poor or white, or you know, in whatever position that they are. Being that voice, again, as Dr. Stanford said, has been really refreshing. We do need to start listening to medical professionals more, because this is our lane. This is what we do. This is not, you know, some political issue. Wearing a mask is not political. It's not. I don't understand like what the issue around that is. If physicians are telling you that this is what it is, then this is what it is. And also, lastly, I want to mention that just recently there was a group of physicians on Capitol Hill talking about that they had the cure to the coronavirus, et cetera. And then you dig deeper and you find out that these are the individuals who were funded, the same individuals that are funding these individuals to go to Capitol Hill were also individuals who were pushing to open up the economy as well. So I think we really need to take a step back and listen to who's saying the message, who has it, and then reaching out to individuals who you feel who are like-minded, who look like you, again, which is important, and who you trust. And I think once you do that, you'll get the right information, you'll be steered in the right direction.
I think from my perspective, I can maybe look at a little different view. Is I'm originally from Southwest Kansas. I grew up on a farm in the middle of nowhere. And I mentioned my 1-year-old son, we had a Zoom birthday for him on April 30th. So just after the peak of the surge here in Massachusetts, I had family on Zoom call from Kansas, from Colorado, from California. And what I remember from that call is, you know, as much as we didn't want to talk about COVID-19, that we talked about it. And our experience here in the Northeast was quite different from what my relatives in Kansas were feeling, although they were also on stay-at-home orders, right? And so we didn't have a great visibility early on as to what the relative risk was in different communities at the time. And so here in Massachusetts, our experience with COVID-19 in March and April and May was quite acute, right? Most people know someone who tested positive, or a friend of a friend, or a family member, or, you know, unfortunately maybe knows someone who passed away. That wasn't necessarily the case all over the country. And so now, you know, where we're at in the situation, our testing has improved. We have more visibility on it, but really understanding the relative risk of these different communities and providing targets for people to work towards, right? Because there wasn't really a targeted on-off switch for stay-at-home orders. It was sort of blanket across the country because we really didn't have great visibility on this and where it was going. And so one of the things I think is really important is how do we provide information to local communities and give them targets and goals of where they need to work towards, because it's really hard to understand where your personal actions affect, you know, a nation of you know, over 300 million people. And so if we can, in my mind, and this is some of the work that we've been doing with the Harvard Global Health Institute, is how do we provide, you know, those targets and think about how they fit into the economic discussion, into the reopening of schools discussion, right? And can we get, you know, local communities in a way rallying around some of those targets. The other one I'll just comment on, and this is something I heard in a meeting with the global or the Greater Boston Interfaith Organization, is that a lot of times when the messages change, the message changed, but we don't actually just explain why we changed it, right? We don't go back and pull back what the other message was and explain why it's changing. And so when people may have heard really early on, don't go buy masks, there's a shortage, we need those for frontline workers, they here don't use masks. And in certain instances, that message sticks. And when we change to, we really need to wear masks, it's different now. It's not always explained as to what's changed. And I think this is a very dynamic situation. And those relative aspects of it are very important.
So I think the communication problem is at least twofold. I think there's sort of two sources of bad information, one of which we might hope to correct, and one of which we can only confront. And what I mean by that is we live in a very unjust and society, and there are people who have an agenda that requires them to say things that aren't true, right? If your agenda is to reopen the economy, it's not safe to do that. And so there is a message coming from, certainly leadership and government at many levels, which has an agenda which I think is contrary to providing good information. And I don't know what you do about that. If people are willing to be dishonest and immoral, that just has to be confronted. There's not a better way to communicate with that message. It's bad behavior, and it has to be confronted and called out. The other thing that's out there is, I think there is a lot of confusion, and I've thought a lot about this, from the popular press, and I think also we've seen this problem in the scientific press as well, in that everybody wants to know the answers about COVID. And so every little piece of information gets jumped on and promulgated and shows up on the front page of the Washington Post, even, preliminary small observational studies and stuff that's really not vetted information. And that can contribute to the misinformation. And, there's a parallel to that. Some of you may be aware, maybe not, that there's sort of this, over the last several years, this ongoing reckoning with the quality of the nutritional literature, because people will publish small studies and it'll get picked up about eat this, don't eat that. And it seems like the advice changes every couple months, and before long, people don't trust what's being said. Anytime a new article appeared in JAMA or Lancet or the New England Journal during the outbreak, it guaranteed was picked up on CNN and the Washington Post and the New York Times. And there wasn't necessarily context for that. And so lots of confused messages got out there. And I think there are ways to think about better communication and better standards that can deal with that. I think when you have people who are pushing an agenda and saying things that are dangerous and untrue in service of that agenda, it's hard to figure out what a better way to communicate with those people is. They just have to be confronted and called out.
Okay, thank you. And as many of your points in the past have talked about underrepresented communities, whether that be homeless communities or communities of color, that leads us into our next question about the fact that many people are wondering why people of color in the United States have become the main target of a disease that has already infected over 16 million people worldwide. What are some disparities in healthcare that have been brought to light recently, especially in underrepresented communities? And if Dr. Armin Henderson, if you'd like to take that away.
Okay, should I go as we were? It was muted before.
Oh, no problem, continue.
Okay. So the first thing I'd like to say, and every chance I get, is as doctors, we do not blame the patient. And so every time I hear someone say it's the social determinants of health, it's because African Americans have more hypertension, obesity, poor nutrition, and their diabetes is not controlled. They don't take their medications, they're non-compliant. It makes my blood boil. I graduated from medical school 23 years ago. That's what people said then. So we're here now, and there are very real, tangible things that are happening. For example, in Philadelphia, you still need a prescription to get a test. You still have to come between hours of 9 and 5. There are rarely weekend hours, rarely night hours. Most African Americans are front-facing employees, so they're out there keeping the country going right now. There's bias in the hospital when one employee can't get tested because their supervisor says they're not sick enough. And still you need a state issued ID even at Walgreens and CVS to get a test. Why do you need a state issued ID? You need a referral from your doctor. And if your doctor is not on staff where you show up to get tested, you can't get tested. So why? I say that there are too many restrictions that the medical establishment has put on testing, and that is the reason why. So when people say the virus doesn't discriminate, it may not, but the people who hold the power for the testing, the treatment, and the resources may, be it by omission or commission, implicit bias or not, it exists, and it is quite prevalent right now, even in July. And everyone on this call has been speaking about it, and it's still present.
Yeah, I agree. But stepping back from a public health standpoint, I think that we don't talk enough about the social determinants of health. And what I'm talking about when I say the social determinants of health, I'm talking about where you work, your education level, where you live, if you have access to fresh food, and those type of things, your education. Those type of things really have put Black people, poor people in this country at a disadvantage. I'm going to talk about in South Florida, for example. I'm from Philadelphia. I can talk about Philadelphia as well. But in places like Overtown, which is a predominantly Black neighborhood here in Miami, the life expectancy here in Overtown is 15 years less than what it is for a neighborhood that's walking distance away. And the coronavirus, the virus itself has pretty much exacerbated a lot of the issues that were already causing people to have a lower life expectancy. There are a lot of homeless individuals. There's not a lot of funding for education. The police are there knocking people over the head every 5 minutes. And the list goes on. And so when the housing costs too much, it costs too much to live in Miami, to live in Overtown. And so people have unstable housing conditions. And so when you have a virus that comes along and exacerbates those things, you know, if you have 4 or 5 people living in a house, it's impossible for you to social distance if you have coronavirus. And so, you know, speaking to like immigrant families who also live more than, you know, 2 or 3 people in a house as well. And so we've seen, and I've seen that, you know, whole families get infected by the virus. And then, you know, if you are an immigrant and you're not like you're not documented, people are scared to go to the doctor. I've gotten like maybe 20 calls of individuals in Miami-Dade County who are saying like, look, if I go to the hospital, is ICE going to pick me up? And that's a real concern. And so people are staying home. They're dying at home because they don't even want to come to the hospital. Black people just don't trust physicians. And so they're not coming to the hospital. The other thing is that, you know, I want to mention is that we live in a capitalistic society. There has been a big push for people to get back to work. People who are low income, Black people, immigrants, specifically in Miami-Dade County, work in these service-oriented jobs. And so now you're being thrust out in the community. You're in front of people who are sick, who want to get back to normal, who are riding buses. These are individuals who work in restaurants. And because we've had this mixed message around wearing masks, now these individuals are getting sick. And they're not going to the hospital because they still have to pay bills. And so, you know, there's no coverage for rent in Miami-Dade County. People can't pay their mortgage. More people are becoming homeless. There's not access to food because individuals are not working. And so you have all these issues that have been ruminating in the United States for years. And I think the virus just really, was the straw that broke the camel's back, basically. And so those are what I think are some of the reasons.
I'll just add a couple thoughts, and I think a lot of socioeconomic factors that have been quite generational, as Armin just mentioned, have really been highlighted in this. And one of the things that sticks out in my mind when all of this started is, when we ask people to stay at home for 2 to 4 weeks, and it's, said, why don't you go to the grocery store and buy 2 weeks worth of food or 4 weeks worth of food? And if we think about the number of people in the US that don't have money month to month, and now we're thinking about needing to go find access to these sort of things or have resources to actually reduce your risk of exposure. And I think there's a lot of different trade-offs in different parts of society that people are having to make. The aspects around public transportation and accessibility to work and types of jobs. I'm quite fortunate in that I have ability to work from home in the situation that I'm at. And I recognize that that's not a possibility for everybody. And I think that there's, in our society, these trade-offs that people are making that aren't necessarily recognized as we talk about how we're putting in place, public health response to actually keep people safe, right? We're putting in people in a situation where they need to choose, do I go get tested and potentially need to stay home for 2 weeks, or do I go back to work where I haven't had a job for 3 months, right? And that's a really hard choice that people have to make right now. And we're having people at the individual level choose between public health or their own individual health versus the economy, right? And I think that's where, when you look at the responses of other countries, they've been quite different, right? And it's responding in a unified way as a country where we're very much not doing that, which comes back to some of what Corey's talked about with leadership in this situation.
Yeah, so I'll just echo something that Dr. Stanford said. This is not a clinical issue. The reason that people of color have been more affected than other populations is not because there's some different distribution of comorbidities or they're more susceptible. This is systemic racism. I mean, I don't think we have to dance around it, and I can try to be a little bit specific about how that operates. So at Mass General, we had 3 to 4 times as many cases as Brigham, which is our sister hospital on the other side of town. We're part of the same health system. And the reason for that is that Chelsea, Massachusetts is in our catchment area and it's not in Brigham. And Chelsea is a lower income, overwhelmingly immigrant community where people are mostly frontline workers. And so they're going to work during the pandemic. And so they're exposed. They don't have the same healthcare access. So they're overwhelmingly in many circumstances, not fortunately for Chelsea because they're in our catchment area, but they're served by healthcare systems that are under-resourced. So for instance, there's a tremendous center-to-center variation in the mortality for COVID-19. At Mass General, our hospital-wide mortality for COVID-19 is 20%. There are hospitals in New York and in other areas of the country where the mortality approaches 60%. And that's 100% about the resources that those healthcare systems have been allocated. And so it's not the virus, it's not the patient, it's the racism and the people who multi-generational families living in the same house. So we had multiple instances of ICUs where we had multiple people from the same household in the ICU simultaneously because the household attack rate is higher than the community attack rate. And if people don't have money and they have a lot of people living in one house, there's going to be a lot of infections. So it's not so much a clinical question. It's more a question of sort of social justice and morality. It's a shame, but I mean, it's more than a shame. It's infuriating, and I will echo what Dr. Stanford said. It's infuriating when people talk about this as being something about the patient or something about the virus. It was a choice that we as a society made to allow that to happen. And we could have and can in the future make another choice, but it was definitely a choice. It was an immoral one, but it was a choice that we made.
Yeah, just following up off of that, that's part of the reason why I have so much of an issue with people who say that COVID-19 has revealed all of these disparities in America. Like, these disparities have always been there. People have just chosen to ignore them. And within like New York City specifically, about 75% of essential workers are people of color. So when the virus first hit, like my neighborhood of East Harlem, I still saw about the same amount of people outside going to work every day. It didn't feel like much of a difference, but then I would see pictures of places like Times Square that were completely empty. And that's mostly because people still need to go to work, and they're making that decision because they need to provide for their families. Most people live in multi-generational households. Most people are from immigrant families. That's the way their apartments are set up. So when governments are over here saying, okay, you guys need to stay home, you need to make sure that you're self-isolating, people are looking at everyone like, how am I supposed to just have my own bathroom? How am I supposed to just have my own room when I share a room with like 3 or 4 other people? So I think it's very unrealistic to give people those kinds of guidelines without giving them the information on how to do so safely. So that's part of the reason why I have enjoyed doing my contact tracing work, because I've seen that so many people who have been infected do come from multi-generational households. And so when I do offer the hotel option, some people don't want to leave the comfort of their home, but some people see the value in making sure that they're keeping their family safe, that they're keeping themselves safe. So I think, like, just going off of everyone else, it's so important that when you're giving people this information, you're also backing up that information with the resources, because otherwise it's not going to make any difference in the long run.
Absolutely.
Thank you. Yes, thank you. Just thank all of you for expounding on some of the factors that just go into contracting COVID-19 and the disparities that exist as well. And our next question is specifically Dr. Harding. In a previous conversation, you mentioned being on staff in the ICU at Mass General. And as we hear stories of hospitals at capacity and insufficient personal protective equipment, I wanted to know what you can tell us about your COVID-related experiences and what you have been seeing in the ICU.
Yeah, I mean, I think in some ways that's similar to the last question, right? Like, we have chosen as a country to have healthcare systems with different amounts of resources. And so I'll be honest, we're fine at Mass General. We saw a lot of patients. We had about 500 COVID patients through our ICUs, a little over 2,000 total COVID patients in our hospital. To give you a perspective, we're about a 1,000-bed hospital, so that's a lot of patients for us. There was sort of a complete abdication of responsibility by the federal government. And that meant that hospitals had to rely on their own resources. And that meant that hospitals and healthcare systems with resources were able to secure PPE. So at Mass General, we're recycling N95s by virtue of a decontamination machine that we purchased ourselves and set up at Assembly Square here in Boston. We were able to secure a number of shipments of PPE by sort of exploiting connections that we had. So for instance, our director of respiratory therapy was the person a number of years ago who designed a ventilator model, which is the main ventilator model that one of the ventilator companies makes. And so we were able to exploit that connection and get 50 new ventilators at the outset of the crisis. And so, you know, I mean, I don't mean to minimize it. Everybody was working incredibly hard to make all of those things happen, but we were able to make them happen. And there are places, you know, the Navajo Nation, for instance, where they couldn't make those things happen. And since the federal government had decided to sit out the epidemic, horrific things happened in those places. So we had a lot of people working really, really hard and really, really creatively to make sure that we had adequate supplies of PPE and adequate supplies of ventilators and things. And I'm just so impressed. And our MICU director, Dr. Catherine Hibbert, made, you know, on a typical day at Mass General in the pre-COVID time, we might have 32 medical ICU patients, and we have about 35, 36 medical ICU beds available to us. Our peak single day occupancy for the medical ICU in the third week of April was 207. And so we built new, you know, we made new ICU beds and we found new critical care providers. And that work was, I mean, it was amazing. It was well done. People were disciplined and smart and compassionate, and it was all amazing. And all of those things happened at other places, and they still weren't able to deliver the outcomes that we were able to deliver because they're places that are starved of resources. And so it's been very, very uneven, and the mortality and the outcome has been very, very uneven. Yeah.
Thank you, thank you. And keeping on that same lines, I have a question here for Dr. Henderson. As Miami has become the new epicenter, what are you also seeing on the front lines?
So yeah, we've become the epicenter, well, in the community, people are scared. I mean, there's a subset of individuals who feel like they shouldn't be going to work, and they are. There's a mask mandate here in Miami-Dade County, and yet there are subsets of individuals who can't afford masks at all. So now, as of maybe 2 weeks ago, the county has now started to provide those, but they're inadequate in their response to doing that. In the hospital, I work at University of Miami Hospital, which is unique because we sit right next door to a major safety net hospital, Jackson Memorial Hospital, which has, like 1,500 to 2,000 beds, and they take care of all the indigent population. So I think they absorb most of the patients that come in for COVID-19. But University of Miami is a small hospital, and I want to say like 75% of the patients that we see right now have coronavirus. Because we are a small hospital, and I think our staff are doing the best that they can, but we are severely understaffed as well. I think, when looking at it from a patient's perspective, yes, there are individuals who are succumbing to the virus and having morbidity and mortality. But on the physician level, I think that individuals are really burned out. We're tired, and I don't really know how long individuals are going to be able to hold on with not a lot of staff on board to help us out. And then in the homeless community, our local government has taken the stance to criminalize individuals who are unsheltered. Now individuals can't be fed by people who want to feed homeless individuals in large groups. And then homeless individuals can't be within 50 feet of a business. And so, now it seems like the homeless population has been relegated to certain areas. And we closed down our shower site, and now we're actually opening it back up. Actually, tomorrow we have things coming in to reopen the hygiene site. We're going to continue to test individuals and provide care to individuals on the street. But yeah, it's a lot going on, and we're not ready. We're stretched thin, and so at some point, I think we may see what happened in other places that were overwhelmed.
Thank you, thank you. And before we go into our Q&A, I would like to offer up one more question. So let's see, our former president, Barack Obama, said, "Change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek." What has driven and motivated you to be the change you want to see in society?
That's like, there's not enough time. On so many levels, I want this society, this world to be better for my 3 Black sons. I want the elderly people who have never had a Black doctor see someone take care of them, because they sacrificed so much for me to be where I am right now. Dr. Henderson can appreciate, I was born and raised in North Philadelphia, which is one of the poorest parts of the city. and have become a pediatric surgeon. So I know both worlds. I can sit at the table and have these conversations with the health commissioner and the mayor. And I can also be in homeless encampments and bus terminals where people are smoking crack on the bridge and we're doing COVID testing. And I'm comfortable in both places. So for me, the motivation is there was not enough being done for people who look like me in this city that I love so much. And I'm not a child anymore. I'm a grown up, I'm a doctor, I have skills, I've been trained well, and it was my responsibility. I didn't ask for permission, I just did it and then asked people to join me. And now I spend a lot of time advocating with city government, and I don't even think they're intentionally trying to deplete resources from the Black community. Sometimes I think they just don't know. They just really don't know. And I've taken on the charge to educate and teach them and say, yes, the elderly, they are vulnerable, they're high risk. But the nursing homes in Philadelphia and the area are 125,000, but African Americans represent 705,000 of our 1.6 million. So where's all the effort going for them as we're taking care of everyone in the nursing homes? And not that we shouldn't, but that's where the money went. And all the CARES Act money went to hospitals that, as Dr. Hardin said, are in a surplus in our city. And there was no extra effort to go to the communities that were being hit the hardest until we showed up in 2 vans and opened up in a parking lot. And so I continually push for that every single day to say, we're here. You have more resources. We need your help. You need to put it in the hardest hit areas, and you're missing the mark. But I'm not going to critique you on it. I'm going to help you so we can get there together.
Yeah, right. I can appreciate that, Dr. Stanford, being from Philadelphia. But here in Miami, in South Florida, as I mentioned, we have a community emergency operations center in which we've been responding to other crises, hurricanes, because we sit on the cusp of climate change. And so, you know, when this pandemic presented itself, we were ready. We had the networks already laid out, and people were expecting me to do what I've been doing. And so I really didn't have a choice. People were like, hey, we got to do this, let's do it. And so, yeah, I mean, I guess that motivates me. And also knowing that, again, if we're not in those communities, if we're not showing individuals how it's done, then no one's going to talk about it. No one's going to do it,
Mm-hmm.
or they're very late to the party. And I think what's most important is that when you do show up and you do a good job and you get good press, they're like, oh yeah, we want you out now. Let's do it. Let's get those resources going, because it makes them look bad, you know. And but I'm glad that I'm in a position that I am in to serve my community, and you know, we're going to continue to do it.
So I think from my perspective, you know, Dr. Stanford, Dr. Henderson, and Dr. Hardin, they're out there really, what I would say, doing the real work. They're putting their lives, their health on the line. They have families of their own. And what I saw in this situation is, you know, there's an opportunity to be a pessimist about the pandemic. There's an opportunity to be an optimist about it. I felt I had skills and background where I could actually help maybe tip the scale one direction. And so I wanted to be an actionist in this situation. And I think what I found in all of this is that given how distributed this is, it's affecting every community and others in different ways, is that it really is going to take everybody to participate. And so I think what's really important is that people recognize that and understand how they can help. And I mentioned here in Massachusetts, you know, early on we were looking at April 10th to April 20th for the peak surge, and it got pushed out closer towards the end of the month. So what that meant for our effort at the MERT is we were actually able to get 1 million more pieces of PPE out to the front line during that time period. right? And that delay wasn't because of my actions. That was because people that were following stay-at-home recommendations, that were taking this seriously as best as they can. And so I think it is a large community effort in this. And for me, it's, you know, what can I do in this situation to help? And I feel like if I didn't get involved and just hoped for it to get better, right, we haven't seen that somebody's just going to come and fix it for us. And I think one of the things I really hope that we carry forward from all of this, and at some point, as Dr. Stanford said, get on to, you know, what's next and how we move forward, is that in some of these situations where we have been able to come together as communities, that we can think about what do we want to do proactively, right? What are some of the problems that we haven't been actually making choices to solve, right? That we've just continued to let carry on. And that kind of local leadership and community development is some of what I really hope we can carry forward.
Yeah, I will say two things that have I think driven at least my involvement in our response. One of them and is just anger. I mean, it's been really infuriating, the decisions that were made and the consequences to people. You know, I mean, the ignoring of testing, the terrible inequities in resource allocation, and you know, this was all predictable. People who follow these things knew in January when China closed down Wuhan precisely what was going to happen here. We knew it. We talked about it. We had meetings about it, and for a variety of reasons, people chose to ignore those warnings, and also the inequities that have resulted in really, really unequal outcomes have been around for years. We knew they were there, and we could have chosen to act on them earlier. So I think a little righteous anger is okay. There have been some infuriating and immoral things that have happened. On the other hand, I've been really inspired by what can happen when an institution works. I'm very proud of my hospital because we were in a situation where the people who were supposed to help, you know, our fellow citizens chose not to, and we don't have the resources of the federal government or even the state government, but we stepped in and did what we could. And so when we became aware that our outbreak was primarily being driven by Chelsea, we created testing resources at our health center in Chelsea. We sent our personnel to knock on every door in Chelsea, and we made a commitment at Mass General to create packets of testing information and hand sanitizer and masks for every household in Chelsea, and we delivered them ourselves. And so I've been very inspired by my institution, and at the same time, I think that's an example when you have a functional institution and an institution that wants to make a problem better, it can be done. And so that's very inspiring. It's also very infuriating because we're one hospital and we're a very well-resourced hospital, but if the government had chosen to function that way, a lot less people would have died. So I can't put a finer point on it than that.
Yeah, for me, I think it was a feeling of being tired. In Harlem, I saw that the government didn't really care about us until gentrification started really going around like 2009. I mean, obviously it was starting off way before that. But before that, like that's not when we saw a lot of the resources that we do have now. And then just being a student studying public health, I felt like I had some skills, but I'm not a graduate yet, but I do have enough knowledge and enough passion for my community to use that in some way. So I know there's a lot of students who are listening, and there's so much happening in the world through like the protests, and then obviously this pandemic. Just because you're a student doesn't mean that there's not a way for you to be involved. There's so many different ways for us to all be involved as a community, even if it's just explaining to someone what contact tracing is or they answer the phone call. Like, that's one important way of helping out. So just using your voice was something that I've learned for myself in the last few months. You don't have to be an expert to be someone who is helpful in this world. So that's just a leaving message that I'll leave with you guys.
Thank you. If we can have one panelist respond to this question from LaToya Anderson of DEP TV News. It's in reference to the conflicting messages around the time frame that COVID-19 positive patients can remain symptomatic from? If anyone would like to answer that question.
I'll say something about that. Sorry, did somebody else answer that? Dr. Stanford?
No, go ahead. No, go ahead. And I can chime in with what I've seen experience-wise.
I think people can be symptomatic for, I think there's two things, right? There's symptomatic and there's test positive, right? And I think as long as the patient is symptomatic, it's quite likely that that patient is infectious. And people are symptomatic for various amounts of time. The average is, less than a week or so. Antibodies start to peak right about the time that patients first become symptomatic. And so on average, the infection is under control by 5 or 6 days after symptom onset. That can be out to 14 days. And that's just, that's just a distribution, right? So there are patients who are going to be symptomatic much longer. Some confusion has arisen from the fact that patients can be PCR positive for a great deal longer than that. And that can be, I think our record is something like 64 days that a patient was PCR.
Hello?
Okay, not sure.
Hopefully he'll come right back. So
Dr.
I
Stan-
think what he was trying to say is that 64 days that a person was still PCR positive, and then there was some literature that came out that it was actually the antigen or just sort of residual viral capsule and pieces, if you will, that were still picking up, but that people were in fact negative. So there was the question, do you need a negative test to go back to work or not if you're asymptomatic? And every hospital has, a different policy. But Dr. Hardin, maybe you could comment on separating that from people who still have residual symptoms, but are no longer PCR positive, like the folks who are still short of breath and have the residual disease in their lungs. And maybe the gentleman I just met works in a factory where he's exposed to toxins and has had pneumonia, even though he's 40, and then he has COVID pneumonia. He's no longer positive. He was positive back in April, but even seeing him, he was still short of breath, but not PCR positive.
Yeah, and I think it's going to take, I don't mean to dodge your question, but I think it's going to take a long time to sort this out. There is, it's well recognized that patients with post-ICU stay, for instance, even prior to COVID, develop something called Post-Icu Syndrome, which can be exercise intolerance and persistent dyspnea and all kinds of symptoms. And so I think in somebody who has persistent symptoms of dyspnea and exercise intolerance, it's very much a challenge to sort out whether that's a sequela of severe illness or whether that's continued to be to the virus. There are also, and you would know better than I, particularly in the pediatric population, these sort of post-infectious inflammatory disorders that are not active viral replication, but are sort of sequela of the severe illness. And so I think for any individual patient, it's challenging to sort through that differential, right? I think PCR is very, very sensitive. So I think there's certainly a population of patients who remain symptomatic but are no longer have active viral infection. And whether that's a post-ICU syndrome or a post-infectious inflammatory disorder, it's probably some of both, depending on the patient.
Definitely.
It is true. I'll just say one other thing. It is true. It depends on the time frame too. There is some indication that there's a population of patients with more severe disease who have a failure to control the virus. So if we're talking about patients who are still symptomatic at like the 3-4 week, that could actually still be uncontrolled viral infection. A lot of those patients do end up in the ICU. So I think it's hard, and it's just going to take a lot of painstaking work and statistics to sort out what all of these things are.
Thank you. And as we bring the panel to a close, do any of our panelists have a last-minute message for our audience or a reminder of personal responsibility in the pandemic?
Dr. Henderson, you should go first, and we'll go after you.
Okay. Well, Yeah, I mean, you know, I think as one of the panelists said, I forget which one it was, is that you don't have to be an expert in the field to help someone out. There's a lot that we don't know about the virus. I'm gonna be honest. Sometimes we're just like, I don't know what it is. I don't know. And I think that if we're listening to the right people, if you know, for example, when I'm calling for volunteers to volunteer at the shower site, every little bit helps. If you can take someone to the hospital, if you can provide them with a place to stay, if you have an open Airbnb and they need a place to stay, open it up. You know, I think at this point, you know, we have to take care of each other. And I think that because the government is not going to take care of us. And I think that we've seen that, particularly around, you know, the response to poor people. And I think the more that we act in community, the more that we lift each other up, the more that we provide for other people. You know, if someone doesn't have a mask and you have 500 masks, give out the masks, you know, and not hoarding things to ourselves. I think the better off we'll be with this virus. And I think among Black people, that's what we've always done, sort of, kind of, because we know that, you know, sometimes we don't always have everything that we need, but when we depend on asking our neighbors for things, that's how we survive. And I think that's what it's about. It's about survival at this point. So yeah, community, being in a community with people you love, and yeah, that's what I got to say.
I mean, that was great. I was going to say, and when people ask me, when is it going to be over? When is it going to be over? It's going to be over when it's going to be over. Your plan should be, there is no plan. Stop making plans, then you won't be disappointed. Find a piece of joy in every day. You know, my mom and I, we've started hugging back to back, you know, driving 90 minutes to Atlantic City to find a piece of beach for 60 minutes for my kids that's not overrun by a bunch of folks. Just the ride there and back, and for them to run in the water and come back in a socially distant way brings joy. You can still find joy in this. Don't be in such a rush. You know, most of us who are medical people, and you know, too, in New York, I don't want to mispronounce your name, it's delayed gratification. All this training, delayed gratification. We all know it very well, but a lot of people don't. So just reassure them it's finite. It's not going to last forever. We just need to be patient. Just tell yourself Thanksgiving's not going to be the same. Christmas is not going to be the same. But every day you wake up to see a new day and you take a breath and see a day you've never seen before, that's a gift. And that's what I would focus on, is that.
Thank you. Thank you for those points that you guys have brought up and for each of your contributions to this discussion. And I would like to thank all our attendees for tuning in. Please feel free to reach out if you have any questions about this event or would like to request a recording. I hope you all enjoy the rest of your week and stay safe. Thank you.
Thank you.
Thanks. Bye.
Bye, everyone.
Thanks for those 3D mask shields. We really appreciate those. That's the one thing we don't run out of, because people are making those in labs everywhere. So thank you. They really go a long way.
Glad you guys are finding all of this useful. But thank you guys all for your work. And Gabriella, thank you for including me in this.
Yeah, this was great, Gabriella.
Thank you.
Good job.